Hi everyone. Don't mind my voice for this lecture. I'm just getting over the flu this week and I've been waiting for my voice to get back and it just hasn't done so. So I'm going to try to record it and just have my cough drops with me and my tea, and hopefully I can make it through and everybody can hear me clearly enough. Okay, so this is perfusion, more specifically talking about heart failure and shock. So this is your CLM, learning outcomes, basically learning about the concept of perfusion, describing the patho and everything, clinical manifestations of heart failure, shock, cardiomyopathies, risk factors, prevention methods, sort of how to care for patients when they're in heart failure or shock, and what are different therapies, medications, testing that you may see with these patients. Definition. So perfusion simply means the flow of blood through arteries and capillaries delivering nutrients and oxygen to the cells. So we all know that perfusion is an essential function of the heart, and basically it supplies the rest of the body with all of the oxygen nutrients that it needs. Okay, so it's something that we obviously cannot live without. Just to sort of review the heart a little bit, if you think of the sort of the way that the blood flows through the heart, you're going to have blood returning from the body through the vena cava into the right atrium. So that blood is deoxygenated, right? It's coming back to the heart, looking to be pumped into the lungs to be reoxygenated. So it comes in from the body into the right atrium, and from the right atrium, it crosses through the tricuspid valve, and it goes into the right ventricle. So the right ventricle will then pump the deoxygenated blood through the pulmonary artery, our pulmonic valve, into the pulmonary arteries and capillary beds, so that way it can be sort of reoxygenated. It gets all its nutrients, gets its oxygenation again. And once it goes through the capillary beds, it then comes into the left atrium. Okay, so now the blood coming into the left atrium is all of that oxygenated, nutrient-rich blood that the rest of the body's looking for. So it comes into the left atrium, passes through the mitral valve, down into your left ventricle, and then from the left ventricle, it is pumped out with a forceful contraction through the aortic valve into your systemic circulation. And that's all your oxygenated, nutrient-rich blood that's being pumped out from the heart into your circulatory system. Okay, so try to picture that in your mind, because the whole concept of perfusion has to do exactly with that. If there is a component of that cycle that's not functioning properly, then your body's not going to be able to get the nutrients that it needs. Okay, so all the other cells in your body, all the other organs that should be perfused with all this oxygenated blood won't be perfused optimally if there is an issue somewhere within the function of the heart. Okay, so then there's another term, ischemia, you've probably heard of. Excuse me, with Ginny. So ischemia is when there is decreased blood supply. So this is where tissue is sort of becoming hypoxic. It's not getting as much blood and nutrients as it should be. And if that is not reversed, then that tissue is going to die, and which would be necrosis. Okay, so that another term for necrosis would be like infarction. So if you had an infarction of your heart, your myocardium, that is what we call a heart attack, where you have an injury to your heart and there's an area of heart cells, myocardial cells, that have died because they have not received oxygenated blood and nutrients. Okay, so if it does reach to that point where it becomes necrosed or infarcted or cell death, then that is irreversible. Okay? Basically, you have your optimal perfusion. Okay, that's meaning everything is going well, everything's being perfused as it should, all the organs and cells are receiving their nutrients and oxygen. Impaired perfusion would be, as I just discussed with ischemia, there's still some perfusion to cells and tissues, but it's decreased and it's sort of hungry for more nutrients, whatever cells or tissue that are being affected. So that can be any tissue in the body. And then no perfusion would mean that you have tissue death or necrosis or infarction. All those words mean the same thing. Okay, so changes in perfusion, they can be temporary, long-term, or permanent. And it all depends on, the degree of impaired perfusion and whether or not it leads to no perfusion at all. There are many different risk factors. Okay, I know that Jenny probably talked about many of these when discussing perfusion with coronary artery disease, but we typically identify them in two different groups. So non-modifiable risk factors would be your age. So typically, the older you are, the more at high risk you are for cardiovascular disease. Okay. The male gender tends to be at higher risk. And also your race can also put you at higher risk. You can see there, African Americans tend to have a little bit higher risk than some of the other races. And then some modifiable risk factors would be those type of risk factors that you have some control over. You have the ability to maintain these risk factors and not let them get any worse, or maybe not let them start at all. So, for instance, high blood pressure or hypertension is a modifiable risk factor that is a huge risk factor for cardiovascular disease. So especially if hypertension goes uncontrolled, that can lead to many complications such as cardiomyopathies and heart failure and everything we're going to discuss. Elevated cholesterol levels, obesity, diabetes, oral contraceptive use, also smoking and drug and alcohol abuse. Smoking can lead to, your arteries sort of hardening and leading to atherosclerosis and, just puts you at higher risk for cardiovascular disease. And same thing with alcohol, puts you at high risk for cardiovascular disease, because when people drink excessively, that will eventually put strain on many organs in your body, and it does end up affecting your heart and can lead to cardiomyopathy. Okay, so those are your risk factors, and you probably notice these are very similar to what Ginny has discussed in her lecture as well. Okay, so then with central perfusion. So this is basically your heart's ability to pump enough blood to meet the metabolic demands of your body. So we talk about cardiac output a lot, and that is basically the amount of blood that's pumped out by your ventricle into the pulmonary circulation, to your systemic circulation, with each heartbeat within 1 minute. So the way that we can determine that, your cardiac output, is stroke volume and heart rate. So these may or may not be some terms that you have heard before, but stroke volume is basically sort of how much your ventricles are able to pump out and how much blood is left behind after the contraction is done. So you hear about diastole and systole very often. So basically, it's how much volume is being sort of pushed out and how much is being left behind. So it's, the difference between your end diastolic volume and your end systolic volume. Okay, so this isn't something that you can just look at somebody and know what their stroke volume is. This would be someone who has, hemodynamic monitoring in an intensive care unit, being monitored with multiple different ICU level lines and monitors and everything. So it may sound a little bit confusing to you. But basically just knowing that your stroke volume times your heart rate is what determines your cardiac output. So on average, adults usually have a cardiac output about 4 to 8 liters per minute. So that's how much blood your heart is able to sort of pump through and circulate into your systemic circulation every minute. Okay, and your cardiac output is so important because it really is your biggest indicator of your heart's ability to function as a pump. So if you have a poor cardiac output because your heart is not pumping effectively, then you're going to see that during your assessments of your patients. So you may see that their pulses are diminished, maybe they have hypotension, low blood pressure. There are many different signs and symptoms of low cardiac output. Even a change in mental status could indicate that someone is not perfusing well. Okay, so central perfusion has to do with your cardiac output, meaning is your heart being effective as a pump in generating the amount of blood that your body is demanding. Okay, and tissue perfusion is basically the fact that the blood that is ejected from your heart is able to flow through the targeted tissues. So that way, all the different tissues, cells, organs in your body, everything is being fed with its oxygen and nutrients. Okay, and there's a little picture there again to sort of talk about the circulation of blood that I discussed earlier. Okay. Of impaired tissue perfusion. So you can have problems with occlusion of veins, arteries, such as an MI that you've talked about with Ginny. When there's a myocardial infarction, there's inclusion, there's tissue death. Okay. Also, constriction can cause issues with perfusion as well. If your vessels are constricted and you have increased systemic vascular resistance because all your peripheral vessels are constricted, that's going to put a little bit harder work on your heart to perfuse optimally. And also dilation of arteries and veins can alter your perfusion as well. So ischemia we've talked about. I'm not going to go in depth with that again. I think I've touched on it enough, but certainly if you have questions, we'll discuss it in class. Assessments of your patients. you want a baseline history, okay? You want to know as far back as things like their family history for cardiovascular disease, their own history for any sort of cardiovascular disease, a basic, head to toe sort of history. Have you had problems with, mentation, just being able to stay awake all the time? Are you having issues with almost fainting? Things like that could sort of give you a hint that there might be an issue with perfusion to the brain. So just obtaining a baseline history, sort of jumping into questions about their family's past and gathering your data. And then also more focused history you would obtain based on their problem at hand. So, we'll talk more about heart failure patients, but if they're coming in with heart failure, you're going to assess sort of like their acute symptoms that they're having with that acute exacerbation of heart failure. Okay. So with examination findings, tissue perfusion, you'll see changes in perfusion depending on what tissue is involved. So like I just mentioned before, if there is some sort of ischemia to the brain or poor perfusion to the brain, someone may have syncopal episodes where maybe they're fainting, don't really know why that's happening to them, or they're near fainting. That could give us an indicator that there's poor perfusion to the brain. Also, issues with perfusion to the brain would be an occlusion of a vessel in the brain. That would be your stroke patients, right? And we would notice huge neurological changes if they had an occlusion in one of their vessels. So it depends, what area of the brain's being affected. Obviously, if it is, for instance, a stroke patient, if they're stroking on the right hemisphere, they're going to be showing all their signs and symptoms on the left side of their body, and vice versa. If they're having issues on the left hemisphere, they're going to be showing all signs and symptoms on the right side of their body. So you'll see those sort of evident examination findings when someone is having issues with perfusion. Okay. And then we have diagnostic tests. So I'm not too sure if Ginny went into any of these specifically, but just to touch on them quickly for you. So angiography is basically when someone receives radiopaque substances and they take x-rays so they could look at blood vessels, lymph vessels, and look for adequate perfusion. So they can kind of see whether or not that, radiopaque substance has traveled all the way through a vessel or all the way through some lymph vessels by x-ray. So the arteriogram is similar in the fact that it looks at the arteries. It can kind of determine aneurysms, and again, if there's blockages somewhere. Echocardiogram, so that is like an ultrasound of the heart. So echocardiograms can also be invasive, which would be your transesophageal echocardiogram. You see it there at the end of the little paragraph, TEE. So transesophageal echocardiogram is your invasive echocardiogram. And this is where they actually use a probe that goes in through the esophagus and looks at the back side of the heart, okay? So that would be your invasive, but your sort of everyday echo that you hear of more frequently is the non-invasive echocardiogram, and that is just transthoracic, meaning that it's just the ultrasound probe over your chest wall, and they're able to look at the function of the heart. They're able to sort of see how the blood flows through the heart and also determine somebody's ejection fraction from that, okay? So your ejection fraction is the percentage of diastolic volume ejected from the heart during systole, okay? So it's how much of that volume in the left ventricle is being ejected out, okay? And for normal individuals, you want an ejection fraction around 50 to 70%. I typically try to stick to like 55 and better. But on average, it's going to be about like 50 to 70% in a normal individual without any cardiovascular compromise. And then hemodynamic monitoring. So that would be like in your intensive care unit settings where you have special IV catheters that are placed that are called central lines and central IV catheters that can determine someone's cardiac output, that can determine many different pressures within the heart, like your pulmonary artery wedge pressure and, sort of look at all the different pressures in the chambers of the heart. And then also you may hear things like arterial blood pressure monitoring. And that is simply like basically it looks like a very large IV catheter that is placed into an artery. And it can be either in like your radial artery or your femoral artery if you had to. And it's placed there either by like a anesthesiologist or intensivist and sutured in place, and that way you can get a continuous blood pressure monitoring. Okay, so that would be considered an invasive blood pressure. So if you've ever noticed, I don't know, in clinicals, when documenting vital signs, it will say non-invasive blood pressure. That's your typical, cuff around your arm, non-invasive, using a regular cuff. And if you've ever noticed an option for invasive, that would be like your arterial blood pressure. That's that special, very large IV catheter that's placed by a physician, and it can continuously monitor someone's blood pressure, more or less in an intensive care unit setting, okay? Electrocardiography, so you have your EKGs, which I know Ginny briefly talked about, and you'll talk a lot more about next Thursday as well. Okay, so those are generally speaking many of the different tests that you're going to hear about when assessing perfusion and the cardiovascular system. Okay, so then for clinical management, primary prevention. So this is basically trying to prevent the development of cardiovascular disease. So you want basically a heart-healthy lifestyle. So this would be like a heart-healthy diet. Maybe someone is, on a low-salt diet, low-sodium diet, low calorie, making sure that they are taking in all of their different vitamins that are essential, things such as exercise, maintaining, I guess as much exercise as is recommended by their physician, but generally it's, exercise a few times a week, at least 30 minutes, just to maintain healthy heart lifestyle. Also, no smoking, avoiding excessive drinking, anything that could possibly put you at risk for the development of cardiovascular disease. Secondary prevention would be screening, also making sure that you're diagnosing things early, so that you can promptly treat them. So that way you can hopefully prevent, lifelong complications or further complications. Routine screening, you can see there, includes like your blood pressure, monitoring your lab work, like your cholesterol level, lipids, your renal functions, and everything else listed there. Okay, collaborative interventions, so that would be working alongside with your collaborative team. So that could be like nutrition, some sort of physical therapy or exercise plan, other things like smoking cessation, whether they speak with like respiratory therapy. I know where I work, that's who does all my teaching for smoking cessation. So utilizing sort of your interdisciplinary measures to care for patients with cardiovascular disease. And then your interrelated concepts you can see there. So pain, clotting, mobility could be a huge issue, especially patients with, heart failure, who have cardiac compromise, nutrition, inflammation, gas exchange, absolutely, as well, simply because of the gas exchanges that happen within the pulmonary capillary beds in order for that blood that's going to be perfused to adequately perfuse all the tissues and the rest of the body. So that plays a huge role. Elimination, when we talk more about heart failure and sodium and water retention, you'll see how that comes into play. Cognition, because of perfusion, it could cause perfusion issues to the brain, and that could affect your cognition, and also patient education. Okay, so then into heart failure, our first exemplar. So heart failure is basically defined as the inability of the heart to meet the tissue requirements for oxygenation. So somewhere along the line, the heart is unable to pump adequately, or possibly fill adequately with the adequate amount of blood it needs to perfuse to the rest of the body, so that all of the tissue and cells and organs get the nutrients and the oxygen that they need. So there are many different causes to heart failure. Hypertension is definitely one of the big ones. Arteriosclerosis, valve disease. We'll talk a little bit of valve disease for the second half of this lecture. And also cardiomyopathies as well. So before I go too much further, I do just want to mention cardiomyopathies briefly, and then we'll talk about them again in class on Monday when we go through my recap slides with you guys. So cardiomyopathies are basically an issue within the heart that the heart muscle cannot pump effectively. So there are different types of cardiomyopathies, and sometimes people may just sort of be born with genetic, hereditary issues, with something like a dilated cardiomyopathy, if you've heard that or seen it in your readings. That can be hereditary, but also cardiomyopathies can be caused by, sort of secondary problems as well. So that can be issues such as like ischemia that leads to cardiomyopathies, or toxins such as excessive alcohol intake, or even cocaine can lead to cardiomyopathies as well. But basically, the three that we're going to talk about are dilated cardiomyopathy, because that's the most common. Then there's hypertrophic cardiomyopathy, which again can be hereditary. And then there's a third one, restrictive cardiomyopathy. And restrictive is really more of a rare form of cardiomyopathy. But those are the three that we are going to discuss in class. And I'll give you a little bit of a handout sort of to distinguish the three of them. But they kind of, or at least to me, I don't know if it's just with my experience, but they sort of explain themselves. So with dilated cardiomyopathy, what do you think that means? Like, what do you picture in your mind when you hear dilated? You think of everything being sort of enlarged, right? So your dilated cardiomyopathy, you're going to have sort of like bigger dilated chambers of the heart. So your atria and your ventricles, they're all going to be dilated. The heart's sort of going to look sort of like a blown up balloon or something, okay? So dilated cardiomyopathy means that you have your dilated heart chambers, they're enlarged, okay? You have impaired pumping when someone has dilated cardiomyopathy. Their ventricles are not able to pump effectively just because of how they are sort of over enlarged and dilated, okay? That can lead to heart failure, and management would simply be managing their heart failure, managing them because they're at risk for dysrhythmias. They may have an implantable cardioverter defibrillator. You know, if you've heard of an ICD, someone has almost like kind of like a similar to a pacemaker, like it's implanted under their skin and has the wires connected to the chambers in their hearts. And it is put into people who are at risk for lethal dysrhythmias, because if their body goes into that dysrhythmia, the implantable cardioverter defibrillator will sense that and give them a shock and defibrillate them out of that lethal rhythm. So they may, have an ICD placed, or they may even need to have a heart transplant as well. Okay, so that's dilated cardiomyopathy. And then hypertrophic cardiomyopathy. So again, the wording to me kind of makes it clear. Hypertrophic. You should know that word from basics back when you started learning medical terminology. Hypertrophic simply means enlarged or like more muscle mass. So if you have hypertrophic cardiomyopathy, your ventricle muscle mass is going to be bigger, okay? So your muscle in your heart is going to be enlarged and bigger, which can lead to issues with being able to adequately pump the blood out of the left ventricle. Okay, sometimes if your ventricles are so hypertrophied, they're not going to pump effectively, and possibly even may cause some blockages if they are really hypertrophied, that the blood can't even really get by the muscle to get out through the aortic valve. Okay, so with hypertrophic cardiomyopathies, this patient population is at higher risk for sudden death. So some people may not even know that they have this disease, and sometimes we even see it with like young athletes. They may just have sudden cardiac death because they had this unknown hypertrophic cardiomyopathy. So treatment with hypertrophic cardiomyopathy would be, again, possible need for the implantable cardioverter defibrillator. That's your ICD, because they're at risk for dysrhythmias. They may also need a pacemaker. may also need medications to control their heart rate. So things like beta blockers, medications to sort of help minimize the risk for dysrhythmias, so something called anti-dysrhythmics. And then things like your calcium channel blockers. Okay, so that's your hypertrophic cardiomyopathy. And then your restrictive cardiomyopathy, again, this is your more rare occurrence. So this can be caused by like radiation or scarring to the heart muscle. And basically your ventricles get stiff. They get really rigid and sort of restricted. So again, the name kind of speaks for itself. It tells you what is going on. So restrictive cardiomyopathy, the ventricles are rigid and restricted, and they do not fill with adequate amounts of blood. Okay, so if they're unable to stretch, the ventricles can't stretch because they're rigid, then the blood is not going to be able to effectively, pool into that ventricle in order for it to be pumped all out into the systemic circulation, if that makes sense. Okay, so again, with restrictive cardiomyopathy, they may also lead to heart failure because the left ventricle is not receiving all of the blood that it should be. So some of that blood's going to be backing up into the pulmonary vessels and capillary beds and cause congestion there and can lead to right-sided heart failure. So management of restrictive cardiomyopathy would be the management of heart failure, and these patients would possibly need some exercise restrictions as well. So they may be, those type of patients where you're really encouraging very frequent rest periods, and not trying to cluster too many activities at once with them. Okay, excuse me. So those are your 3 cardiomyopathies that I do sort of want you to be familiar with. And again, I'll have a worksheet for you guys in class on Monday, but I wanted to mention them now because of how they do put patients at risk for the development of heart failure. Okay, so with heart failure, they typically will have, clinical manifestations of fluid volume excess and poor tissue perfusion. All right, it is a chronic condition, so it's sort of going to be like a lifelong treating. It's progressive, and again, it's because the heart is unable to pump enough blood into the circulation to meet the body's demands. So what are you going to see when patients have this? So you can see here that there are 2 boxes on your screen. Okay, we kind of split them up between left-sided heart failure and right-sided heart failure. Okay, so that's what we'll focus on for, this lecture now. But sometimes you may hear of, in practice or in clinical, people talking about systolic heart failure, diastolic heart failure. There are many different terms, but we're going to talk about right-sided and left-sided. So depending on which component of the heart is malfunctioning, you're going to see different clinical manifestations. So if somebody is having left-sided heart failure, they're going to have a lot of pulmonary and respiratory signs and symptoms. And the reason for that, if you think back to the way that I was describing how blood travels through the heart at the beginning of this lecture, it'll make a lot more sense to you. So if you have blood that's traveling through your right atria, the right ventricle, goes into the pulmonic valve, into the pulmonary system, it's oxygenated, gets its nutrients, comes into the left atrium, and comes into the left ventricle to be pumped out into the rest of the circulatory system. If that left ventricle is malfunctioning somehow, and it's maybe not pumping all the blood that it should pump out into the circulatory system, maybe it's holding on to too much blood, so there ends up being sort of a backup of blood from that left ventricle into the left atrium and back into the pulmonary system. You're going to start to see patients with crackles when you auscultate their lungs, because they're going to have congestion from all of that circulatory backup, right? So I hope that makes sense. So you have blood that's coming in on a normal heartbeat. It's going to come in from the left atrium, from the pulmonary vasculature after it's been oxygenated. Left atrium, come down into the left ventricle, and that left ventricle is supposed to pump it out into the circulatory system. If there's a malfunction there, blood gets left behind, and that next heartbeat, where the blood starts to try to come through that left atrium into the left ventricle again, it's not all going to be able to come in because there's a backup, okay? So when this backup happens, you start to see your pulmonary clinical manifestations. So again, your congestion, which is like your crackles on auscultation. People may exhibit with hypoxia or low oxygenation levels, okay? You'll see it on their O2 sats, low O2 sats. They may have dyspnea on exertion. So they may tell you, oh, well, when I'm at home, I noticed I tried to get up from my chair in my living room to go to the restroom, and I had to stop 4 times to catch my breath. So they were having dyspnea on exertion while walking, okay, or during some activity. They may also have orthopnea and paroxysmal nocturnal dyspnea. So when people have orthopnea or sorry if that just delayed there. My computer logged me out. Okay, so back to where I was. So if someone has orthopnea or paroxysmal nocturnal dyspnea, a short for that is PND. These are your patients who are typically going to say, I sleep at night with, 3 pillows under my head, because they have to be elevated in order to sleep and feel as though they can breathe adequately. If patients are, sleeping flat, they may wake up acutely short of breath, which can be frightening for them. And they may have to sit up and sort of catch their breath, and then they use the pillows. Or sometimes you may hear of patients even sleeping in recliner chairs, because that's how elevated they need to sleep in order to breathe adequately. And then these patients may also have a dry, non-productive cough initially, but that can lead to, with a more severe decompensation of heart failure. It can lead to more of, if you've heard of like that frothy sputum, if someone's coughing up sort of like that frothy, white, maybe a little bit blood-tinged sputum, that would be an indicator of pulmonary edema. And pulmonary edema is when there's an abnormal accumulation of fluid in the interstitial tissues and alveoli of the lungs. And that is because of all of the backup congestion of, circulatory volume and blood that is not being pumped out by the heart into the rest of the body. It's being backed up into your lungs and causing pulmonary edema. So that's in severe cases. And when patients exhibit pulmonary edema, it really is a medical emergency, because they are not able to breathe effectively. Okay. I can tell you that I've seen many patients with acute decompensation of their heart failure, they're in the hospital for an acute episode of their heart failure. And, maybe they were admitted to a medical floor first and they were doing okay, but all of a sudden they worsen. And the nurses on the regular medical floors may call like a rapid response or something. I'm thinking of a scenario particularly that I went to probably within the last 6 months or so. And it was a rapid response for an elderly male. And he was in for heart failure and acutely started desaturating. They couldn't get his O2 sats out of the 80s. His work of breathing, you could see him using his accessory muscles. They really had him sitting, straight up in the bed, like almost 90 degrees in the bed because he just could not breathe adequately. You could see him just using every muscle to try to breathe. And then another sort of, indicator to me when I arrived to this situation that this was most likely related to heart failure was because his mouth was basically almost like foaming with white frothy sputum. So he was in what we call like a flash pulmonary edema, okay? And that just means that your pulmonary system is being sort of overloaded with fluid and it's now affecting the way that you're able to breathe, okay? So that's your left-sided heart failure. You're going to see all your respiratory symptoms there, okay? You may also see too changes in mental status. I didn't mention that with low oxygenation levels, right? If someone's hypoxic, you're going to see a change in mental status. So that could also be a sign and symptom of left-sided heart failure, especially if someone is in an acute, decompensated or worsening situation, all right? And then there are different heart sounds that you may hear of or you may even have read in your book, such as the S3. So your S3 is heard early and diastole, okay? And with the S3, it's sort of called like a gallop, and your AV valves open up and the blood flows into the ventricles, and that blood flow into the ventricles sort of causes a vibration that causes that extra heartbeat, okay? So it's how you hear of your S1, your S2, that's your typical like lub-dub for a heartbeat. So the S3 is an extra sound that you would hear upon auscultation, okay? Sometimes that can be heard when someone has severe left-sided heart failure. And then your right-sided heart failure. So this is going to be your systemic signs and symptoms. So like basically the whole rest of your body is going to show signs and symptoms. So you're going to see jugular venous distension, okay? That's because you have, increased fluid circulating around. So if you have someone laying in a bed and you notice in their head of the bed is, between 30, 45 degrees and their jugular vein is distended, that shows that they may have fluid overload, which can be contributed to right-sided heart failure. This can be caused because the right ventricle, so again, thinking back to how the heart works in a normal individual, the right atrium empties its deoxygenated blood into the right ventricle, And then the right ventricle should push that blood with a contraction into the pulmonary system to be oxygenated, right? If there is some sort of resistance that the right ventricle has to overcome to sort of more forcefully contract that blood and push it into the pulmonary system, eventually over time, the right ventricle may wear out a little bit, okay? It kind of gets tired, may not work effectively. And when that happens, sort of the same thing as the left side that I was explaining, you still have that deoxygenated blood trying to come in from the right atrium, right? Because the heart is still beating. So the cycles are still happening, even though this right ventricle is not working as it should. Say it pumps some of the blood out into the pulmonary system, but some is still sitting in that right ventricle. Well, that right atrium is going to try to empty the next, load of blood into the right ventricle. It's not going to be able to effectively empty. So it's going to end up with a sort of backup or congestion into the systemic vessels. Okay, so that's why you see a systemic clinical manifestations with right-sided heart failure, because your right ventricle is sort of causing a backup into the right atrium, into your inferior and superior vena cava, and into the rest of the vessels in your body, okay? So it causes an overload of fluid in your systemic circulation. So that's why you see your jugular venous distension. You're also going to see dependent edema. So that's like, when someone's sitting in a chair and you notice their ankles swell up like big balloons, okay? Hepatomegaly simply means that the liver is enlarged, again, having to do with perfusion and overload of fluid circulation. Ascites, due to leakages between the cells at the cellular level, fluid sort of leaks out of the cells into the interstitial spaces, causing ascites. They may have weight gain, and may also have anorexia and vomiting. They may have some abdominal pain, depending how bad their hepatomegaly is. The enlarged liver may be uncomfortable for them. Okay. And also their extremities may be cool to the touch, just because of the congestion is sort of sitting in the major organs that need the perfusion. So there's sort of less perfusion to the periphery. So you may have like cooler hands, cooler feet, and that sort of thing. Okay, so that is the difference between the two different types of heart failure. I hope that it sort of makes sense to you when you can think of the way that blood should normally flow through the heart. And then when I break it down into how it becomes abnormal, whether it be left-sided failure or right-sided failure, okay? But one of the big things to remember is that your left-sided is going to be all the pulmonary respiratory clinical manifestations. Also have some cognitive manifestations if they're hypoxic. Remember that, okay? Low O2 levels. And then your right-sided heart failure is going to be your systemic clinical manifestations. So that's like all the other signs and symptoms in your body. So that's your fluid overload, your edema, your enlarged. So nursing care for these patients. Respiratory status is very important because of how I mentioned that fluid overload due to the ineffective pumping of the heart can sort of lead to respiratory complications, such as like the pulmonary edema that I mentioned. So you want to be sure that you're auscultating the lung sounds People who are fluid overloaded, you may hear crackles or rales, wheezing. They may need oxygen therapy, depending what their oxygen saturation level is, depending on, physician orders. Typically, if someone is in an acute episode where they are desaturating and they're having an increased work of breathing, you're going to apply oxygen, emergently, and then get in touch with the doctor to let them know what's going on and obtain your order. For positioning patients, Fowler's position allows them to, sit in an upright position and allows them to have adequate chest expansion, really helps people to feel as though they are able to breathe better. And then there's also something called like CPAP, or continuous positive airway pressure. And we'll talk about this with our oxygenation lecture. It's a form of non-invasive ventilation. And when patients are in heart failure or have acute decompensated episodes of heart failure, where they're in the hospital, they may need CPAP or something called BiPAP, which is very similar to CPAP, okay? And this is basically like a big mask that they wear on their face, and it provides some amount of pressure with each respiratory cycle to help them adequately breathe, okay? So it decreases their work of breathing and sort of gives them a little bit of extra pressure so that they can oxygenate well and breathe a little bit more adequately, okay? But again, don't worry too much about that right now, because we're going to talk a lot more about CPAP and BiPAP and all of that with the oxygenation lecture. But I just wanted you to know that it is something that can be used for patients with heart failure who are having respiratory compromise. Okay, so fluid volume for nursing care. So they may need to be on fluid restrictions, and it's not going to be the same for everybody. It depends on how severe their heart failure is, okay? Sometimes you may see people on 1,000 milliliter fluid restriction, or maybe it's 2,000. Depends on the patient. They'll be on low sodium diets, and it's extremely important to educate the patients who have heart failure to report any weight gain of 2 to 3 pounds in one day, okay? So they should be monitoring their weights every single day at home. And if there's any increase in their weight by 2 to 3 pounds within a day, that's something significant, and they have to report it to their healthcare provider. Okay. Pharmacological therapy, I'm not going to go into detail right now with the recorded lecture, simply because we're going to do an exercise in class. Okay, but we will go through each and every one of the pharmacological therapies. Okay. On to shock. So there is so much that I could possibly say about shock. They are very complex states. When someone is in shock, they are extremely ill, requiring, intensive monitoring, and most likely will be in an intensive care unit, critical care unit setting. So stages of shock, you have your initial stage, which really we don't see any changes on the outside. We don't see any assessment changes. They're just having changes internally at the cellular level, okay? Then there's compensatory. So this is when your body starts to compensate. Your body knows that something is not right. There's an injury, there is something going on that your body's trying to fight. So it tries to increase the cardiac output to maintain adequate perfusion and oxygenation. So this is where you might see someone is tachycardic, their heart rate's gone up, or tachypnic, their respiratory rate's gone up, okay? They may at this point have a normal blood pressure or maybe a slightly higher blood pressure because they're vasoconstricted, okay? So their body's trying to compensate for the injury or insult that is happening to them, okay? Progressive. So this is when your compensatory mechanisms start to fail. So your body cannot maintain an adequate blood pressure or mean arterial pressure anymore. And I don't know if mean arterial pressure is something you're familiar with, so I do want to touch base on that really quick, just in case you're not. But your mean arterial pressure basically determines whether or not you're perfusing your organs adequately. So it's something we go by a lot in the ICU. When we look at somebody's blood pressure, if you've ever noticed on like your blood pressure machine, when you get a blood pressure, you get your systolic number, your diastolic number, and oftentimes another number that maybe is like right below it or to the side of it or something. So that's your mean arterial pressure, or your MAP, M-A-P. So the way to get that is if you didn't have a machine that told you what it was and you only had what someone's blood pressure was. Say someone's blood pressure was 100 over 80, okay? So you have a blood pressure of 100 over 80. I'm just going to write that down here. So 100 over 80, how do you figure out the MAP? So the equation to figure out your MAP, or mean arterial pressure, you want to do your systolic. So I'm writing this here on my paper. So systolic plus your diastolic number multiplied by 2. So diastolic times 2. And we'll go over this in class, so don't worry, okay? So then you have your systolic plus your diastolic times 2 divided by 3, okay? So in this instance, if I have a blood pressure of 100 over 80, my systolic number is 100, okay? So I have 100, and I'm going to say plus, my diastolic is 80, right? So in parentheses, I'm going to do 80 times 2, which would give me 160. So now I have 100 plus 160 is 260. So 260 divided by 3 gives me a MAP, or mean arterial pressure, of 86. Now that is a adequate mean arterial pressure. For mean arterial pressure, you want anywhere from, say, like 70 to 100, okay? That means that you're adequately perfusing all of your organs, and your organs are receiving, the nutrients and oxygen that they need. So if your mean arterial pressure starts to drop, say it starts to get, more towards 60 or more towards even lower down to 50, that means that your organs are at huge risk because they're not being perfused well, okay? So we oftentimes look at the mean arterial pressure to determine whether or not our cardiac output is adequate and we are perfusing, okay? So with the progressive stage, you start to see your compensatory mechanisms fail, meaning your blood pressure and your MAP start to fail. They start to decrease, okay? So your vital organs are not being perfused very well anymore. You may also have lactic acidosis in this stage, okay? So if you've heard of something called the lactic acid, we'll talk more about when talking about sepsis in a minute. But that just determines, how much acidosis is occurring in the blood. And then the cells in your heart and your brain start to become hypoxic during this stage, okay? And then the worst stage is your refractory stage. So refractory stage is irreversible and basically total body failure. And you at this point have had too much cellular damage. There's no treatment that can reverse the damage that has been done. And unfortunately, the individual will expire or pass away. Okay. So refractory stage is irreversible and is not something that can be treated. So just to talk about two types of shock, cardiogenic and septic. So cardiogenic means that the heart cannot pump effectively because of a cardiac factor. So something has happened to the heart, and now the heart cannot pump effectively to maintain an adequate cardiac output and adequate tissue perfusion. Okay? So there's some sort of insult or injury to the heart. So this could be things like a myocardial infarction, okay? Especially if someone has had an anterior myocardial infarction, they are at high risk for cardiogenic shock because the left ventricle, is right there anteriorly. And if there is a large degree of damage to the heart muscle of that left ventricle, then the left ventricle is not going to be able to pump effectively, right? So cardiogenic shock can be due to things like a heart attack, MI, lethal dysrhythmias that cause damage to the heart, okay, and pump failure. So that can even be like your heart failure, okay? And then septic shock, which you may have heard of because it's really frequently discussed, I think, in current practice. I know where I work, every patient on the medical floors is being screened for sepsis. I believe every shift is how it's supposed to be done by a tool called the early warning score. So basically, with sepsis, this is a circulatory shock that is caused by an infection. Okay, so an infection has started somewhere and now has gotten into your bloodstream and is starting to spread. Okay, it's becoming systemic. So sepsis is a leading cause of death for patients who are in intensive care units. I think, again, coming back to me saying that it's been a very popular topic for discussion recently, and that's sort of, I think, part of the reason why is because of the huge high mortality rates that are associated with it. So when someone develops sepsis, they are not just automatically going to be in septic shock, okay? There are different sort of levels of sepsis, okay? Your initial stages of sepsis are going to be where your body's inflammatory response has kicked in. So that's why you see here it's characterized, where it says it's characterized by warm, dry skin, bounding pulses, and tachypnea, because that's your body's initial response to the infection, the inflammatory response, right? So you're going to start to see somebody sort of like flushed appearance, right? They're going to be warm, sort of anxious, and sort of know that something isn't right. That's sort of your starting point of sepsis, okay? But as sepsis worsens, people can develop septic shock, and that again would simply mean that they're unable to maintain an adequate cardiac output or mean arterial pressure to, perfuse the body adequately, the tissues in the body adequately, because of this overwhelming infection that is taking over. Okay? So those are the two types of shocks that you should know. I know that there are multiple other types of shocks, and I know Karen Manning will discuss like neurogenic shock and things when she does some of her lectures. But for, this lecture and for exam 1, it'll just be expected that you sort of know the difference between cardiogenic shock and septic shock. Okay? And we'll talk about clinical manifestations in just a second on the next page. So, manifestations. So you're going to see that someone is not perfusing adequately, okay? So decreased perfusion. So they're going to be tachycardic. They're going to have low blood pressures. Remember, I was talking about the low decreased cardiac output, decreased mean arterial pressures, okay? That kind of all comes along with hypotension, poor perfusion. They're going to be tachypnic, have a fast respiratory rate. They may start to show signs and symptoms of other organ involvement. So they may have oliguria. They're not going to make a lot of urine. Okay, so oliguria is manifested as less than 30 milliliters an hour. They may have cold, moist skin when they are in shock. But remember, the parentheses there says not septic, because the initial sort of presentation of sepsis, when it initially starts to occur, when your body's in that inflammatory response stage, that's when you're going to have that warm, flushed appearance, okay? Warm skin, flushed appearance. But if they become more progressively septic and lead to shock, then yes, they're going to have cold, moist skin, because they're not going to be perfusing well. For their color, they're going to be very pale, okay? With cardiogenic shock, you may see cyanosis, because again, their heart is not adequately pumping oxygenated blood. So that's going to mean that, all the other tissues are not being oxygenated. So you're going to see cyanosis, along with hypoxia. Metabolic acidosis. Again, I mentioned lactic acidosis briefly before. They have a buildup of lactic acidosis in the body. And decreased LOC, or change in mental status. Okay, so people may exhibit as being restless. They may feel really anxious, or they may progress to lethargy and difficult to arouse or unresponsive. So for patient care, you want to position the client in a position that's going to optimize perfusion to the brain. So typically we say, to lay them flat or slightly Trendelenburg, which means, when they're laying flat in the bed, you sort of tilt the bed so that they're almost sort of like upside down a little bit, not hanging upside down or anything, but they're just sort of tilted upside down so that the blood flow and perfusion to their brain will be better. You want large bore IVs, okay, because especially septic patients, they're going to be getting a lot of IV fluids. So you're going to want to make sure you have those large bore IV lines. And that's generally like a gauge 20 IV or larger. Okay, that's usually what is considered large bore. Okay. Administer oxygen is needed. Again, monitoring their O2 saturations will sort of guide you as to whether or not they need oxygen, but you can imagine if they're not perfusing well, they are going to need some form of oxygen, okay? If they're in the ICU, they may end up even on a ventilator, being mechanically ventilated because they're unable to oxygenate or breathe adequately when they are in shock. Vital signs are taken very frequently if someone is in shock, especially if they are on medications to maintain their blood pressure. such as vasopressors. Again, we'll talk about the medications on Monday. But anything that is, how do I want to say it? Very potent, such as a vasopressor, and can change your hemodynamics so drastically, you're going to need to monitor them very frequently. So it says every 5 minutes here. That can just be a sort of rule of thumb if someone's in shock initially. But once they're on vasopressors and you sort of are able to manage them a little bit, I know where I work, my practice that we do currently is vital signs every 15 minutes for these patients. But just know that vital signs are going to be very frequent, okay? You promote rest and decrease movement. So these patients are going to be on bed rest, okay? You may do a little bit of passive movement with them just while they're on prolonged bed rest because you don't want their joints to stiffen up or anything. But you don't really want to recommend like active range of motion because that's using up oxygen that they can't really afford to give up at this point. They need to conserve every bit of oxygen so that their organs can be perfused adequately. So they'll be on bed rest, maintain rest. Monitor urine output. So again, these patients are most likely going to have a Foley catheter. In the intensive care unit setting, their urine output would be monitored very closely every hour. And again, a goal of 30 milliliters an hour or more for urine is adequate. Anything less than that is considered oliguric. You're going to monitor labs. So you're going to monitor gas exchange through arterial blood gases, which are your ABGs. Again, I know you've learned those in 1020, I believe. Don't worry too much about them now. We'll talk more about them with the oxygenation lecture in a few weeks. Your lactic acid. So you want your lactic acid to be less than 2 for a normal patient. If it is elevated, that is signifying that someone may be septic. Okay, so when lactic acids are elevated, that's an indicator of sepsis, and also an indicator that we're pretty soon going to be starting IV fluids for those patients, okay, and antibiotics and everything else. I'll talk about treatments in a second. Also monitoring serum glucose levels, cardiac enzymes, blood cultures, urine cultures, wound cultures, if it's someone who is septic, and coagulation studies. Okay, so coagulation studies would be like your PT, INR, PTT. When someone is in shock, they have a risk for going into disseminated intravascular coagulation, which means that their body basically cannot coagulate adequately, okay? So they're at very, very high risk for spontaneous bleeding and hemorrhaging leading to death, okay? You also want to maintain a normal body temperature as best as you can, because if someone is septic, initially they're going to be febrile, so they're going to have a temperature. But as they progress through the stages of sepsis, when they become more like septic shock, their body temperature can actually be low and hypothermic, okay? So it's important to monitor that as well, okay? So now on to the treatments. So for cardiogenic shock, you're going to focus on increasing the contractility and reducing the afterload. So I know we didn't talk much about afterload just yet, but I will be talking more about it in the valve lecture, okay? So with cardiogenic shock, you're going to be giving medications such as vasoconstrictors, so like your vasopressors. You want to give medications such as dobutamine, norepinephrine, nipride, nitroglycerin. Again, we'll talk about these medications on Monday, so don't panic, okay? You also want to be sure that you're maintaining adequate urine outputs with someone in cardiogenic shock as well. They may need diuretics depending on the patient situation. So that would be your treatment for cardiogenic shock, focusing on increasing contractility and reducing the afterload. Then with septic shock, so I mentioned earlier, when someone is septic, they're going to be getting a lot of IV fluids. So they basically will be getting 30 milliliters per kilogram of IV fluids. A lot of the times they are receiving like colloids, crystalloids, like anything sort of to just sort of like fill up their tank, okay? So we give them a lot of IV fluids, sort of flush out their system. You want to check the lactate levels that I mentioned, okay? And when they start to go above 2, that's when they're considered positive. You want to obtain blood cultures in patients who are septic. So before any patient receives an antibiotic who is septic, they need to obtain blood cultures because you want an accurate reflection of their infection that is going on in their bloodstream. If you give an antibiotic before you obtain that blood culture, then there's a chance that that antibiotic could already affect whatever bacteria is in the bloodstream, and maybe it would alter the results of the blood culture. So that's why we do it in that order. So you get your blood cultures, and then you give your antibiotics, which are oftentimes broad spectrum antibiotics, okay? And then if patients sort of do not turn around with that little bundle that I just talked about, then we go on to adding in vasopressors. So vasopressors would be needed when someone's mean arterial pressure keeps falling below like 65, because that is telling us that they're not adequately perfusing, okay? So in NCLEX world, the adequate map is 70 to like 105, but in general practice, what you see a lot of times is a map of 65 and greater. So if someone's not able to maintain an adequate mean arterial pressure, and you've given them all their IV fluids that they needed, so that's the 30 milliliters per kilogram, right? And, you know, you've given them their antibiotics and they're just really not turning around. They continue to get worse and their body cannot perfuse and oxygenate all the tissues and organs. And you see it reflecting in their mean arterial pressure. That's when they need a vasopressor. So that's a medication that's going to bring up your blood pressure. And those are the potent medications that I mentioned a little while ago. Again, ICU setting. Okay, so those would be the treatments for the 2 types of shock. And we will go over these again in class. So please, if you have any questions or something that seems unclear to you, write them down on your notes now. And we can go through them all in class on Monday and help to sort of make sense of everything and organize everything for you guys in the best way that works for you. All right. So after this, I'll have you listen to the valve lecture, and that will be it for Monday's lecture. Okay? Thanks.